let's go ahead and move to our next slide, looking at our important dates that we want all of y'all to be aware of. The Wave 1 hospital, which, as we just saw, are Duncan Regional, all of the Integris hospitals, James Phillips, St. John, and Children's OU. You all will be participating in an in-person kickoff meeting on March the 3rd here at the Academic Tower at OU Medicine. So that is our building here at the OU Health Sciences Center. We'll give you more information on that, and Barbara Coop is going to talk here in a little bit, or Denise is, about what we're going to do at these meetings. The next meeting is the Wave 2 in-person kickoff meeting, and that's going to be held June the 10th here at Samus Education Center. We also would like the Wave 1 hospital to attend this meeting. At the kickoff meeting, so if you're a Wave 1 hospital, we would like for all of your team members, as many as possible, to attend that March 3rd meeting. And then for the Wave 2 hospital, which again are Comanche County, Lakeside, Mercy, St. Francis, St. Anthony, Oklahoma City, St. Anthony, Shawnee, and Stillwater. We would like for you all to have all of your team members attend on June the 10th, or as many as possible. And then the Wave 1 hospital for the Wave 2 meeting. It doesn't have to be all of your team, again, to attend that meeting. We would just expect a couple of your team members, and we'll talk more about that as we get closer to that kickoff meeting on June the 10th. We also just received word last week that we have been approved for a buprenorphine waiver training in-person meeting on July the 27th. And this is with OB-specific information in order to get waivers for prescribing buprenorphine. I can't say that today. You must attend an 8-hour class, 4 hours must be in person, and then there is a online portion as well. So we're going to have a waiver training here. This will be for, we said, 25 people, and it will be here at the Samus Education Center in Oklahoma City, July 27th from 1 to 5. So if you have any of your obstetric providers, or they can be OBs or family practice, nurse practitioners, or any addiction medicine specialists who are not waivered to prescribe buprenorphine, please let them know about this training on July 27th, and we will be getting more information as we get this, the packet from the Addiction Medicine Society, who will be conducting the training with some obstetricians who are waivered to prescribe. So we'll be sending that out as we get the information. And then, again, the date for the OPQIC annual summit on October 2nd, 2020. We are hoping to secure a speaker who has expertise in opioid use disorder and pregnancy, Dr. Mishkitz Kirkland. Some of you all heard him speak a couple weeks ago here in Oklahoma City, and he was excellent as a speaker on this, and a speaker about addiction and the science of addiction and the stigma and all of that. And so we'll be very excited if we can secure him as a speaker for the summit. So those are the dates that we want to make sure you get on your calendar. Please spread this information with your team as a calendar invite so they can get the date saved, and let us know if you have any questions. We'll send them more information in the near future. Okay, now, next slide, Barbara Coop is going to take over about things that we would like to, for you to be working on before those kickoff meetings.
Good afternoon, everybody. Thanks for joining us. We have a little checklist of things that we would like to get accomplished before the March 3rd and June 10th meeting. The first thing on that is, I know you have completed a team roster, but we're going to need to add a few people to that, and we'll get into that in a moment. We will be sending you out another spreadsheet probably later today for you to be able to update this. This is adding those new team members and making any changes in people that you may have listed. I would ask that when you make changes and send those back to us, that you please highlight them so that we don't have to go through and compare name by name who is still there and who isn't. The next thing that we're going to have you do is a readiness survey. These are come into three categories. Prenatal. So the question here is how to get in touch with your providers. Do you have a contact person at each office? That's something that you're probably going to need throughout this process, so something you might be developing, whether that's an office manager or whomever you feel is a reliable person there to get information back and forth to the offices. One thing that is different from this than any of our other initiatives is that it does include provider offices during the prenatal period for some of the information that we need to gather. The second group will be inpatient. You can fill that out. And then the third is the neonatal group, which you can fill out. At this point, we're kind of finalizing these surveys. So we plan to get those out as soon as we come back from Christmas holiday, and we would like for you to have those in within a month if possible. It gives us a chance to go through and see what is needed for each one. The other thing we're going to look at is having you diagram your process flow. So when a patient comes into your unit, and we've got some examples for these in a minute, when a patient comes into your unit, where do they go? How is this going to be handled? Make a little more sense. Kind of like when JACO comes and they do a patient tracer. That's a similar situation to what we're asking for here. The next thing is that we're going to schedule in-person meetings with our staff for each hospital. We want to get the wave one meeting taken care of in February, prior to the last week of February. We were thinking that the easiest way to do this, other than trying to get 7 separate hospitals, was that we would meet with the 3 Integris hospitals at one point, the 2 St. John hospitals at one point, and then a meeting with Duncan and a separate meeting with children. That would cut it back a little bit, and we'll look at the next group and see if there's any that we can combine in that way also. This is the team roster that you have previously filled out, where you've included your physician champions, your day-to-day leader, executive leader, a technical expert, although I noticed a couple of people have left out technical experts. That's going to be somebody that has a good, strong grasp of how things run in your unit, plus a good, strong grasp of quality improvement processes. The ones that we have added is a pharmacy representative. We have decided that there are a lot of medication guidelines here, general opioid guidelines, pregnancy-specific guidelines, which include labor and postpartum medications, things like possibly no opioids for the routine vaginal delivery, limiting the number of opioids prescribed when they go home. And then with all the NAS, there's a lot of work with the pharmacy for their medication guidelines also. A data and coding expert. You're still going to have a data entry person, The data entry for this is a little more intensive for each patient, but the good news is you probably are going to have much fewer of these patients than you would have like hypertension patients. So I wouldn't expect any hospital to have very many of these people that they're going to have to, of these women and newborns that they're going to have to collect data on. The other thing we're looking at is coding. Right now on our website, there is a coding guide for intrauterine substance exposure and neonatal abstinence syndrome. It gives you a lot of step-by-step which codes to use when and which ones need an additional code with them. Right now, we're in the process of developing a coding guideline for maternal substance use complicating pregnancy. So we will have a similar thing for the OB side of this. And that may be something that you need to share with that we will be sharing with your providers. Social worker, we decided we need a social worker because they are so often involved in all these referrals. And I'm not sure how familiar all social workers are with the type of referrals that we're going to be doing. They also are going to need to coordinate with the child welfare specialist whenever there is a safe plan of care that needs to, or a plan of safe care that needs to be enacted for a neonate before they're discharged if they have been exposed. So that would also include that social worker would need to help them incorporate previously developed plans while they were prenatally in the hospital or that the medical provider has laid out. So they're going to be that liaison in between the child welfare specialist and the patient. And then others, if you happen to have behavioral mental health child development people, those would also be a good person to add on to this. Probably only the really larger hospitals have those. When we were talking about getting an idea of your process of when a patient comes in, and I realize this isn't very visible here, we don't expect you to put it like this. You can just hand write this. But it talks about when a patient enters your unit, that they're screened, that they're screen negative. And by screening, we mean a validated screening tool that asks questions. If it's negative, they return with regular routine care. If it's positive, are they turned over to a physician who then talks to them about intervention and refers them out to the different people? We'll send you a copy of this, but I want you to know that it is not expected that you do this on a computer, just that you kind of, in some form, map out with pencil and paper how you take patients through this process. I know the one on the left talks about the initial OB visit. This was just an example of how this could look. We're not going to ask you to look into what the provider offices are doing at this time. We can move on to the next. Okay, that's it. Denise, I'll let you take over the diagram here.
Well, as you all are probably feeling, and one of the reasons why it's taken us so long to get this initiative actually launched is because of the complexity of what we're looking at. So the next couple of slides is the diagrams of our drivers that we're using to help achieve our overall aims of this initiative. So if you look at what our aims are, we're wanting to reduce opioid use in pregnancy and fetal exposure to opioids, prevent maternal opioid overdose and death, increase the percentage of pregnant women with OUD who receive medication-assisted treatment and behavioral health counseling, and then overall improve post-discharge or post-delivery social and developmental outcomes for the entire family that's affected by opioid use disorder. So we have some drivers that we're looking at to help achieve those aims, mainly with appropriate opioid prescriptions of women of childbearing age, women who are pregnant, and women who are in the postpartum period. There are several prescribing guidelines on our OMNO toolkit that address those issues. We're looking at identification of pregnant women with OUD and referring them for medicated assisted treatment. And this really is a large focus of our initiative, is initial screening, using experts, doing brief interventions when necessary, and referral to treatment. So finding out what resources are available for women with OUD and then linking them to those resources is going to be a large component. And then providing compassionate care. Barbara already mentioned addressing the stigma that's associated with opioid use disorder and how we actually provide care and use appropriate language whenever we're providing care. And then addressing comorbidities such as HIV, sexually transmitted infection, and hepatitis. So those are more on the OB side of the continuum of this initiative. This slide looks at more of the newborn care, so you can see we have a long list of interventions there on the right, but focusing on increasing identification of newborns that were exposed to opioids. We refer to them as the OEN, or the opioid-exposed newborn, as well as infants with NOW, which is neonatal opioid withdrawal syndrome, which is similar to neonatal accident syndrome, but it's specific to opioids. So a lot of the care of the newborn is looking at optimizing care, the non-pharmacologic care, so focusing on rooming in and parental involvement in the care of the newborn. This may be a challenge for some of you who don't typically care for these infants on the mother-baby unit or in a room where rooming in might be an option, so making this an option for your patients might be a big intervention for you. Also encouraging breastfeeding and the use of mother's milk when appropriate, and then utilizing the Eat, Sleep, Console tool to not only guide the effectiveness of the non-pharmacologic care, but helping to use that to determine if an infant does need pharmacologic care if they have a withdrawal syndrome, and then using a standardized pharmacologic treatment protocol to guide that. And the aim for all of those interventions would be to reduce the length of stay for newborns with a diagnosis of NAS. And then we're looking at post-discharge social and developmental outcomes for the newborn as well when we're looking at early intervention referrals and the plan of safe care. So this is still in draft form. What we anticipate is that hopefully our Wave 1 and Wave 2 hospitals are going to be able to provide us with quite a bit of feedback on our driver diagram and that we can make some modifications to this as necessary. But this is what we're going to use to help you all develop your, what we're referring to as our 30, 60, 90 implementation plan. So you will be determining which interventions you address first and at what time point, what time period during the initiative you implement the interventions. We will be collecting data to help determine if our interventions are being effective. And if you'll see on this slide, there's a list of data that's going to be collected. The items that are listed in blue are those that are going to be collected by the hospital. So it is a little bit different than some of our other AIMS initiatives. These data metrics are currently available on the AIMS website, and when we send out these slides, we'll put a link to that, but if you want to go find on the Safe Healthcare for Every Woman website, if you go to AIMS, you can find the data metrics there. But just like the other ones, there are outcome measures, process measures, and structure measures. This particular initiative also involves some state surveillance measures. So, like I said, the details are in that metric guide. We are in the process of developing one a little more specific to Oklahoma so that we can provide you with better guidance on collecting the data. But we did want you to see the list so that you can kind of start thinking about how you might collect some of this data. And we will be working with you more closely when we come out to your hospital for that one-on-one meeting with our staff, and then even in more depth whenever we are at the kickoff meeting. If you are using ICD-10 coding to help guide your data collection, these are some of the denominators that we're going to be using with our data collection. And defining women with opioid use disorder, there's multiple ways that that can be defined. She can either have self-reported OUD, a positive toxicology screen during pregnancy. She can have delivered a newborn that has an unanticipated positive toxicology screen, and then the newborn with withdrawal symptoms. And newborn is defined as being admitted at 0 days old or is transferred up to 1 week old. When a newborn is transferred, then we're asking that the receiving facility, the one that actually discharges the newborn home, is going to be the one reporting the information for that newborn. The OEM, the opioid exposed newborn, we're looking only at newborns that are greater than or equal to 35 weeks. And again, they were born to a mother with OUD. They either had withdrawal symptoms or an unanticipated positive toxicology screen. And then newborns with NAS, that is the C96.1 code. So again, just things to start thinking about as you start to look at data collection procedures within this facility.
Okay, so this is Barbara O'Brien again, and just wanted to give you some information about the kickoff meeting. So what are we going to do during the kickoff meeting? The first one on March the 3rd for the Wave 1 hospitals, and the second one on June the 10th for the Wave 2 hospitals. We're going to be talking a little bit more in depth about quality improvement. We know that you all have been doing this with previous initiatives, but we want to go a little bit more deeper because this one really is going to take, we believe, more planning, more steps, and we want to ensure that everyone has the knowledge base to go back to your hospital and do a formal quality improvement initiative. We're also going to talk about the data definitions. We know that, and that can also often be an area where you go back to your hospitals and other people have questions about this. So it's important for you to understand what the data is and what data we'll be measuring. So we'll be going more in depth on the data. We will talk about resource mapping. One of the things we'll be asking you to do is looking at resources in your community for the women and the newborns. So what we'd like is ideally for every clinic that provides obstetric care to have a plan, first of all, to do screening, and this is verbal screening on a woman, to identify women with opioid use disorder, and to have a plan if they need inpatient or outpatient treatment, where will they send their patients? So we'll be talking about the resource mapping at the meeting also, and then talking with you all. You'll have an opportunity to work more with your whole team on finalizing your 30, 60, 90-day plan. It doesn't mean we're going to be finished in 90 days. You'll be continuing to make and revise 30, 60, 90-day plans as you go through this process. We do think this is a good way to have those deadlines so that you have 30-day deadlines, you have 60-day deadlines, and you have 90-day deadlines to ensure that people are held accountable for actions and that you're continuing to move in a positive direction here. So that is kind of just a loose agenda for our kickoff meeting. And then after the meeting, you'll begin that implementation of your plan. begin data collection, and this will be through the AIM data portal, as you all have used before, beginning your resource mapping, and also we do, with this collaborative, we have received funding from the Department of Mental Health and Substance Abuse Services for all hospitals in Oklahoma to utilize the Vermont Oxford Network NAS online curriculum. So this will be available to your staff at no cost. Anyone can use it in your hospital as long as, your hospital that's participating in OMNO. And if you have, I believe it's 80% of your staff, and we'll talk with you more about what that means, you'll be able to be designated as what's the name? Do you remember?
Center of Excellence.
A Center of Excellence. So that's something that we'll be talking about at that meeting. We may have the capability to access this curriculum prior to the kickoff meeting, so we will send that to you when we receive this access. And if you want to go ahead and get started with the training, you're welcome to begin as soon as we're able to do that, give you the access. And like I said, we'll be learning from each other as we move along. So, surely there are going to be other things that will be going on after the kickoff meeting, and really deciding what's going to happen in your hospital and how, creating that plan and implementing the plan for each hospital. We anticipate that this will, of course, be different for every hospital, but as before, you all will be helping each other, and we will be helping you. So we're excited to get this kicked off. I apologize for background noise. It sounds like they're doing just started some kind of construction on the other side of the wall in our office here. So sorry if you all hear that. So I think that's all we have for you today. We will open it up for questions, and again, feel free to chat in the chat box, or we will unmute you and you all can go ahead and ask questions verbally as well. And so in order to prescribe buprenorphine, which is a medication given to women who are suffering from opioid use disorder, when you're pregnant, it is not recommended to withdraw the opioid and detox a pregnant woman, because the negative effects that she goes through during that process can have negative effects on the fetus. So what they recommend during this time period is to what they call an induction of the woman, where she's no longer taking her opioid, either something that's prescribed or not prescribed, can be heroin or some other methadone, any other kind of opioid. They recommend that they be treated with buprenorphine, which is a medication that can take away their cravings for the opioid, but they don't experience the high that they got before. So they're more on an even keel going through their daily life, but they're not experiencing the cravings that they do with opioid use disorder. So this is a recommended treatment for these women. In order to prescribe this medication, you must receive a waiver, and there are some specific requirements. One of them is to go through training that has to be a 4-hour online training and a 4-hour either in-person or a video conference meeting. So we are going to be providing the 4-hour in-person portion of this meeting, and it will be more OB specific, have an OB specific focus. We do know that what we've heard from physicians who have taken this training, that it is very good training, even just to learn more about addiction and about buprenorphine, about the treatment. If you don't plan on prescribing and actually using a waiver to prescribe buprenorphine, it still can be a benefit to take this class.
We have one question in the chat that do we expect the kickoff meeting to be an 8-hour event or a few hours? We don't have the exact timeline for the agenda at this point, but we do expect that it'll be the majority of the day, so potentially up to 8 hours. So between a half day and a full day.
Thank you all for your willingness to join us in this and to help and improve the care for mothers and women and for mothers and newborns in Oklahoma, especially for this the special population, and we're excited to get this going. So thank you again, and have a safe and happy time over the holidays.